Welcome back to the implementation track. I am your host all weekend long, Dr. Damon Durker. I'm live from Indianapolis at Eye Surgeons of Indiana. Really excited. This is I can't believe it's already our fifth how-to session, but it's a series about how to do things that you may have learned on the didactic side in the clinical track with the mod, but how to actually do those things in different practice settings, whether it's in a surgical practice, whether it's accelerating in-office procedures, whether it's building your very own dream dry eye center that we saw yesterday from Carly Rose. We're honored to have Dr. Mark Schaeffer here with us to discuss how to implement a dry eye disease protocol in a primary care practice. Mark, welcome to Eyes on Dry Eye.
Damon, thank you for having me. And I'm really excited to be here because implementation is always the fun and hard part of all of this. You know, learning all of the information that we get, especially with dry eye disease, and all of the information that's now out there and all of the different ways we can take care of patients. How do we provide that consistently and effectively and easily in our clinics day in and day out and make the process easy so that not only our office runs smoothly, our staff runs smoothly, and our patients leave with a feeling of, I know that I'm on the right path? Because that's the hardest part of all of this is implementing this protocol, because it creates the sense of safety. It creates the sense of understanding from the patient perspective that, okay, I need to do all of these things. I need to continue with this and see the doctor back again so that we can continue down this pathway of getting better. There is nothing worse than when you have a patient and you see dry eye disease and everything is going well. You've made your recommendations, you've talked about it, but there's a bobble in the handoff. There's a mishap with prior authorizations. There's a loss of patient education there. And now the patient leaves confused, not understanding what's going on. And when you see them back, they don't understand why they're not better, why they don't have clear expectations set forth with them. And now they think that their dry eye is getting worse, even though it's not, right? Like, we know that we can continue to treat these patients. And as long as we're setting that up and setting up the expectations and running smoothly, everything makes life a little bit easier. The staff can get behind it. Everybody is on the same page, and just makes the experience better for the patient. So when they're going through a disease, they now know that everybody in that office understands what's going on. So we know that dry eye disease is prevalent. Depending upon what number you look at, whether it's 35, 45, 55, 65 million Americans with dry eye disease now, it's super prevalent, right? We're seeing it in our exam chairs, and we're seeing it more often in everyday life, and it's affecting the vision. And anybody that doesn't think that dry eye disease is a vision-related problem, we have a lot of talking to do, right? You're in the right place, because dry eye affects vision. It affects contact lens wear. And that's what brings people into our primary care setting every day of the week. They need new contact lenses. They need new glasses. But sometimes they struggle to connect the dots with their symptoms or their signs. And that's where having a great protocol makes that smooth transition into explaining why it's not just a glasses problem, why it's not just a contact lens problem, why there's more going on to the surface. And that's how we can get there. Now, this is not easy, right? Like, implementing a dry disease protocol takes time, it takes effort. That's why we have an entire implementation track. Damon and I, when we first went through this, like, this could be a 4-hour course very easily. So we're going to try to condense all of this into one single hour to kind of get, how do we implement this? So I'm going to go through our story just because it's really interesting to hear. We went through a lot of variations. We kind of went through 3 different ways in which we can identify and isolate the dry eye patient. Because at first, you know, we have vision insurance, we have major medical insurance, and our patients aren't necessarily the best at understanding that. So how do we delineate that? How do we tie in the vision to the medical? When we first did it, we were very hard and fast, right? It was we are here for your vision exam to get your glasses and contact lenses. We identify a problem of some kind, and we're going to bring you back for a full medical workup due to something that we see during the eye exam. And this is a great, easy way to set up in the beginning, just because it is, I'm taking care of your vision. You have a problem that I need to see you back for. So this is the hard divide, if you will, and the true separation of church and state. So this is getting that ability to treat the patient on the front end or really on the back end so that you can do all of the necessary testing at the medical visit. Because when you're here for an eye exam in a primary care practice, if you're anything like a primary care setting, you're busy. Your time slots are valuable, and anything that can cause a backup or a delay in your examination throws everything off, right? So when we think about automating or making things effective and smooth, when you have a new patient or a new symptom, that can kind of throw a wrench into it if you don't have the right protocols and set. So where we ran into problems with this is with the hard divide, it was just patients didn't come back for that 1 month follow-up. They had no reason to, right? So if we established that, hey, you're early dry eye disease, and here's what we see, and here's what we're talking about, we still lost that connection. We still lost that ability to bring them back. They were in the chair that moment, and now bringing them back is even more challenging. We see that in our bringing patients back just for an annual eye exam for new glasses and contact lenses. If you look at the data, average patients come back every 14 months for a contact lens exam, every 18 to 24 months for a glasses exam. You think I'm going to get somebody back in 2 to 4 weeks for a dry eye visit 100% of the time? No matter how good my recall systems are, no matter how convenient my location is, it's a challenge to get people to come back. And that's where we saw, okay, we need to do something different, because the number of people we're diagnosing with dry eye and the number of people we were actually seeing for a dry eye workup, we were able to, in our EHR at the time, we were using Exam Writer, put in a code for a dry eye workup and see percentage of dry eye workups to eye exams. And we were running somewhere between 2 and 3% of our eye exams. Now, if you look at data, 10% should be where you're at on a low end. So I treat a lot of dry eye. So at 2.5 to 3%, that was still super low for me. And so we said, we need to do something different. And that's when we kind of found VSP and other vision plans have a coordination of benefits. And this is where you file to both insurance plans. So you take the day of visit and you file everything to medical if they have a medical complaint, meaning dry eyes, right? Anything related to dry eyes. You file it to their major medical, they pay a copay to their major medical that day, and then you take whatever's remaining and you refile that to their VSP with the claim from their major medical. Now, if you are thinking anything like I am, the moment you hear you're waiting for 2 insurance companies to reimburse you, that's the thought I have, right? But it was a way for us to treat dry eye the day that they came in. But then it became an issue of, I am coming in for my vision exam. My standalone vision plan is anywhere from $0 to $20 of a copay. And now you want to charge me my specialist copay of $50, $75 to switch it around. So they viewed it almost as a bait and switch. And so the last thing I want to do is come off looking like I'm trying to sell them something or collect more money, even though we know this is what's best for our patients. And for a lot of you, this may be a great option too. So everything that we have, that we've gone through, just going through our story and how we came about deciding what we did. But what's awesome is that optometry and every primary care practice is going to operate a little bit differently. So by all means, if you have any sort of pearls for each one of these and you want to put them in the chat for us to go over, or anything in the Q&A, by all means, this is supposed to be interactive because friction makes fire, right? This is where we learn how to put stuff together. And this is how we do it. So coordination of benefits, again, waiting for 2 insurance plans, that lag time of waiting between it, having to have a dedicated person in order to file through all of the vision plans or all of the major medical that we sent off, and then having to refile them on the back end to VSP, IMED, Davis, Spectator, all of those were the ones that were, okay, this is just a challenge, right? We weren't getting the reimbursement we want to. Patients were frustrated with us for having to swap. So then we decide, okay, we need to do something not completely different, but we need to figure out a hybrid of the both. And so what we have decided is where we have gone is kind of a hybrid method of both. If we see the disease, what I like to do is start them on some sort of treatment that day and don't do an extensive amount of treatment. So I like supplementation. I think it works tremendously well for our patients. They need to be on it anyways. It helps with their whole body. I personally use Science Based Health Hydro Eye. I know that there are great supplementation that's out there that you can sell out of your office. And that way the patient leaves with something physical, tangible that they can start taking that day. And what we have found is that the return rate for this is much higher, in the 30 to 40 to 50% return rate, which is incredible to see that doubling and tripling of effect just by handing them and getting them to purchase a supplement that day. Now we've tied it to a problem, we've tied it to an answer. Now we want to bring them back and see how they're doing on their new medication. And at that point, now we can do the full battery of testing with their major medical. So now it's a smoother transition for us into a hybrid type model where it's not a true hard divide, because you have diabetics that come in, you have patients that are glaucoma suspects that you have to manage both. You have to figure out a way to treat the medical and perform the eye exam and do so in an effective manner, because chair time is money, right? We all know that that's a factor here. So how do we settle on that flow? And we kind of went through our testing that we had. We had a LipiView, we have a LipiFlow in our office, we have Tier Care, we have Tier Lab, we had Inflamadry. We kind of have gone through and seen, okay, let's run it for 90 days, see how we're doing. Does this add to our clinical battery? Does this decline? Does this add to patient time in office that's unnecessary? And so we went through and kind of added more things. We took away more things. But at the end of the day, we always do a clinical exam. We're always staining with both listening green and fluorescein. We're looking at upper, lower, everything you see, the lift, look, pull, and press, all of those, the four that Leslie Odell likes to talk about. So that settling of flow is something that you find in your office. You find with your staff. What are they comfortable doing? What can they handle? What can you do as the doctor to make this smooth? And that kind of helps you understand what's going to work in my office and what's not. Now, obviously, the challenge is we're dealing with exam times and chair time where we have a patient every 20 minutes. So that includes full eye exams. We dedicate specific office visits just for medical visits. So we have an early slot and a late slot in the morning, same in the afternoons, that's designed for medical workup. So that way we have their own dedicated time. It's not going to interfere with the number of eye exams that we're performing, so that we can take care of all of our patients. Now, some offices I have seen that do really well. If you have enough patients and have enough demand, setting up an entire morning that is your dry eye morning in a primary care setting. I've seen that been done. I've seen it done well. I've seen it done not well. But the thing that you want to make sure of is that you have the demand and you have the spacing and you have all of the services needed in order to do all of that quickly and effectively. You gotta have dedicated time to discuss all of the treatments. There is a lot that goes on, and not only dedicated time, but dedicated materials. So we have a sheet that has treatments so that we can handwrite it or put things on there in order for us to put on there. So when we have treatments, they leave with tangible things, and it's not one thing that they can just leave somewhere. It's usually in some sort of nice carry bag with all of the instructions, all of the things that they need for that day. And then staff champions. So you'll see all these questions to answer up here. And we're going to get to those in just a minute. But really the challenges with this is having a staff champion. We have turnover, right? We are in a primary care setting. I'm at my eye doctor. We get turnover. We have patients or staff members going to optometry school, going to professional school, moving all together. And so you have to deal with turnover this day and age. And so how do you train your staff? And how do you retain your staff champions? How do you enable them and give them the authority in order to move forward with this and kind of be their advocate through the whole process? You can't answer every phone call. You can't be with every patient. So how do you advocate and have advocates in your office? We're going to talk about training in just a moment, but it all talks about how do we set our goals? So, right. So, making our goals so that we can move forward, so that we can have the things that we want to do. So we want to build buy-in. We want to build buy-in from our patients, and that's getting them to understand why this matters, right? So again, connecting the dots with that vision-related exam, which is why they come in and see you, right? My VSP, my IMED, my vision care plan says I need to come in every year for my eye exam, but my eyes have all of these issues. Okay, well, let's connect that to why you came in today. From the staff, we need to build buy-in that this matters for them, helps them make their life easier when they're in their offices. So what we have done in our office is build lunch and learns around dry eye and every other disease process that's really out there, using live examples of cases that are in our office every single day. Because when you connect it to a human that they have worked with or seen, my favorite activity is having technicians take a picture on the OptiMap, come out and be like, what was that thing on their eyeball? I need to know that. And so creating that awareness, creating that excitement, and creating that ability to educate your patients, or staff, not only on the fly, but also having dedicated time for that. And then getting hands-on training and experience. So this is going to be truly getting your vendors into the office. So training with different types of materials. We just had an in-service with ProCare and having them bring in a live tissue so that they can see what this looks like, having a patient set up so that we can talk about the process moving through it so that everybody is together. Everybody gets one set of information and everybody gets to learn from each other. They can ask each other questions and go from there. And again, if you're in an office that has multiple ODs, we have 4 optometrists in our clinic, 14 exam lanes, we're in 24,000 square feet. So it can be hard to corral everybody together, but having these in-services and having these vendors who are more than willing to come in and help educate as well. I like the tag team approach of having somebody from within the dry eye space come in and sponsor a lunch, have them talk about their product, and then also talk about it from a patient perspective. So clinically, what does that look like? How does that feel? What kind of patients are we looking for? And then the other setting goals is tying that medical to the vision. So treating early, treating often. One thing that I've heard from other dry eye experts is telling your patients that we want to use the minimum amount of therapy to give the maximal results. And I think that resonates really well with everybody across the board, especially patients who understand, listen, this is an ongoing thing. So having that implementation, having that protocol in there so that you can create kind of a stepwise approach so that everything runs smoothly and easily. Okay, if this, then this, if A, then B, and kind of moving forward. So I'd like to open it up just to kind of say, and if you have this, how many of you actually have a written protocol or a standard operating procedure for your dry eye patients, either at an eye exam setting or if they call to book an appointment? Do you have something actually written down? Because having a protocol up here is not the same as having a protocol on here. So how many of you have it? If you do, put it down in there. I want to go back to the patient presents to an eye exam slide real quick, because I think this is where I want to focus some time, is converting that patient, right? So patient presents for their annual eye exam. Any number of complaints, any number of issues, contact lens wearer, yes or no, glasses wearer, first time eye exam. It really makes no difference, right? So this is a 35, 45, 55-year-old patient, complains of blurry vision in their current glasses or contact lenses, and it feels worse at night. How many of you have heard this patient? How many of you had this patient yesterday? How many of you are seeing patients today and had this patient this morning, right? After asking some standard questions, maybe some eye fatigue at the end of the day, they're 20/25 or 20/20-ish in each eye. When you refract them, a quarter of change or not a lot of change gets their vision to a sharp 20/15 in each eye. Right? Sounds like a great exam, an easy exam, right? Like this is a no-brainer. We're going to get you some glasses. We're going to get you seeing better. How many of you dig deeper? Right? I like this point because eye fatigue, blurry vision, these are things that really you don't think about. Worse vision at night. You know, all of these things tie into dry eye disease, especially on the early side, right? They don't complain of the intense watering, or I can't function, or I have to use lubricating drops 15 times a day. If you're in a primary care setting, those people are going to call in with that complaint. Where you're going to catch patients early and where we can have the biggest impact is when you catch them before they become truly symptomatic. So how do we find something that is the early stages of this disease with the vision and connect it? So how many of you push on oil glands on every single patient that comes in? I do. It's always fun to talk about it. I always like asking, have you ever had an eye doctor who does that? And guess what they tell me? No one's ever done that before. I've been seeing doctors for 30 years. No one's ever done that before. But when you do this patient, this 35 to 45, 55-year-old, you see thickened meibum when you push, right? When you pull the lower lid down, you see those shortened altered glands where they're now kinked instead of being nice and smooth. Now, what are you going to do? Are you going to talk about dry eye disease at this point? I mean, we're here for a dry lecture, so like, yes, you are. But in the real world, is this something that we can just smooth over and just be like, all right, cool. Like they've got some early MGD, they're in their 40s. All right. They're not really complaining of dryness though. The one question I always ask patients is, do you feel like your vision fluctuates? If you blink, does your vision get better and stay a little bit better, but then go away? And that is the end of story, right? That is the dry eye question that gets them into treatment faster than anything else. Now, before masks, I could put them in the phoropter and then they would be like, hang on a second, let me blink a few times and clear this up. But now the masks just fog everything up. So now I don't have that diagnostic tool that I once did. So now that we've established there's early MGD, are you using surveys in your office? So we use the speed sheet. It's a fantastic survey. It's easy to use. You can go on dryeyeandmgd.com and download it. It's simple. It's under 6. They don't have dry eye. Over 6, it's a conversation. So we use that. So when you have a patient that has 1+ MGD, and you guys can put it in the chat or whatever, it's just something to think about. Are you treating this? Are you using a dry eye questionnaire on every patient? I always love when we hire new staff members and they're like, well, they kind of complain of maybe some mild itching. I'm like, did you give them a speed sheet? And they were like, no. I was like, well, why not? They're an eye exam, right? Every patient gets a speed sheet regardless, because I want them to tell me that they don't have it. Prove to me that you do not have dry eye disease rather than I have to prove to myself that you do. Because anybody who's a contact lens wearer that has end of day dryness, I'm checking for dry eye disease. Anybody who complains of fluctuating vision, checking for dry eye disease. Anybody who has nighttime vision issues, I'm also checking for dry eye disease. It is more prevalent now than ever before because of all of the different conditions that are out there. So those questions we need to, instead of proving that you do have it, it's easier for me to say, prove that you don't. So that is kind of when the patient presents, those are the easy ones, all right? Those are the ones that you can get a maximum benefit on with a little bit of treatment and a little bit of buy-in. And you don't need a lot from the patients. I can make your vision smoother, easier, and simpler throughout the day. And that is a 4-minute conversation at maximum. So now you've taken 4 minutes and created a patient into a medical condition. They're more likely to come back. They're more likely to purchase services from you and eyewear in a primary care setting because they trust you, because you're helping their vision, not only with the glasses that go on their face, but what's going on within the eye. So when you have that patient presenting for their annual eye exam, this is the opportunity to tie in the vision to the medical. And that's the important part of this annual exam. That's why we want to have these questions set up. And that's why we want to look for the early side rather than waiting for the 3+ corneal staining and my contact lenses, I'm in the latest daily disposable and only get 3 hours out of it. Those are the hard ones, right? Those are the ones where you got to start talking about, here's 9 things we got to start with on the beginning. How do we start with 1 thing? How do you start with just 2 things that create a positive improvement that go on? The earlier we treat, the more on the literature we see. The earlier we treat, the faster it gets better, the better the patient feels, and the more they feel those side effects, or the more they don't have any of those side effects of long-term ramifications. So treating the patient early, connecting it to the vision exam, having that set up in your mind to say, here are where we're looking. So if you're not doing a survey, that would be the easiest thing to implement, is just give them a piece of paper, have them fill it out, and just add it into their EHR. I know that there are ways that you can probably implement it to send it to the patient ahead of time. If you have intake forms that are done online, I know you can do that, and then you can get it put into your system as well. And now, before they even sit down in the chair, you've identified them as having a higher speed score. So now I know I need to talk about it with this patient. Again, you're able to connect the dots for them, show why this is important, show the value, and then they come back, right? So now that we've created that hybrid model of seeing something, treating it, maybe not fully on day one, but we're starting to do something, then we see them back, they're more likely to come back. And so that's the goal, right? Is to bring them back, have them continue therapy and get better. So it makes their glasses wear better, their contact lens wear better, keeps them in contact lenses longer and happier, makes their vision more comfortable and stable. Because at the end of the day, right, our job as optometrists is so that patients can live their life without having to think about their eyes and vision, right? Think about the patient that has to put in drops every hour. They literally have to make their day around doing something for their eyes. The goal is for them to not have to think about it at all. Put in contacts in the morning, I don't have to think about it again until it's time for me to take them out at night. It's the best. That's what we want. We want patients that are satisfied and thrilled. So how do we provide that and implement this into our system? And that's starting early, starting treatment, and asking ourselves the right questions, which now gets into questions we need to ask ourselves and ask our office in order for us to get to the best way for us to treat these patients. So if we want to go to the questions to ask, unless you have something.
Mark,
Damon.
I'm gonna jump in here, and thanks for, very comprehensive look at that. And you did throw out a couple questions for the audience, as well as we have a question coming in. So when you asked, do you have a written protocol? 100% of people that were willing to answer that question said, yes, I have a written protocol. So maybe there's a few shy folks there. I don't think we're batting 100% in the audience, but everybody in the chat said yes. And then 100% of people that answered the question, do you press on the meibomian glands on every patient, said yes. But again, our sample size there was low. So people that were doing that were willing to share. Others, I think, maybe not so much so. But we do have a really good question is when you have this is from David Browning, when you have an annual vision plan patient and they need to have a workup for dry eye, you said you start some sort of treatment to get them back for a medical follow-up. But what if you want baseline data prior to treatment for patient education later on? How would that work?
Yeah, that's a great question. I think it's important for us to have good baseline data. So what I like to start with is the supplement, right? I start with Hydro Eye, which is my personal favorite. Now, all of the clinical data from Hydro Eye tells us that we don't see a huge bump in signs within the first month. So I see them back in a month so that I can get data so they can then I can get all of that. So we're not going to see tear labs get better. We're not going to see their meibomian glands change a whole lot in a month. We're not going to see their corneal staining change a whole lot in a month. All of the other therapies that are out there, it's 6 to 12 weeks before we see a change on the cornea. So I think that we can buy ourselves a little bit of time by prescribing something to get them back in the door that doesn't affect our treatment baselines a whole lot. Their speed score will change in a month or two on Hydro Eye, and we've seen that. But we're not going to change staining a lot. We're not going to change tear osmolarity. We're not going to change a whole lot of that. So we're going to feel a little bit better, which is now more motivation for them to come back. So I'm okay starting them on something, getting them to buy into, I need to take something for dry eye, and then moving forward. But there are some things that, your symptom survey score, if you do a more in-depth like OSDI or longer version, you may see an improvement of symptoms within a month if they're on a supplement like Hydro Eye. So a question that's worth answering, for me, the validity of the other tests that are out there, for me to objectively measure their dry eye, it's not going to make a massive difference or enough of a difference for me to not prescribe something a month later.
Then we had a practice management question. If you're doing an in-office MGD treatment, in this case, the example was a tear care, you do a tear care treatment, would you charge for an office visit at the same time you do some sort of in-office blepharitis or MGD treatment?
That is also a interesting question for us to ask. I do think that it depends on what brings them in, right? If they come in and they're a follow-up visit, and then while they are there, we talk about the procedure and they're like, I want to do it today, right? Their chief complaint or their reason for coming in was a follow-up visit. and then we are doing the service that day. But if they want to just do the service, then we're only going to charge for the service that day. So it really depends on how they're scheduling and what they're coming in for that day, what their chief complaint is, because it always has to tie in. But if I come in for a tear care and that's the only thing I'm coming in for, I'm not doing a full office visit related to it. If they come in for a dry eye check, we talk about doing a tear care and they're like, you know what, I really just want to go ahead and do it today, and we can accommodate that. I'm going to bill for both because we did both. So I'm billing for the services that we're doing and not doing anything inappropriate.
So there's a couple other questions about what happens at these follow-up visits and protocols. So I think you're going to answer that as terms of, questions to answer for your particular office, and what you're doing in your practice may be slightly different than what I'm doing in my practice.
Oh, absolutely. We're a primary care setting. Damon, you're more of in a specialty care setting. You don't get people coming in that's like, oh, my contact lenses are bothering me, and I'm overwearing them for 6 to 8 months at a time. So now it's like, is it GPC? Is it dry eye disease? Is it the contacts? Is it all? Yes, it is, right? Contact lens dropout happens, but if we look at it from a surface standpoint and the contact lenses, we need to do something about both. I think that this is a whole nother lecture, but you got to do something about the surface because that's where the contact lens goes. But our practice, these are the questions that really gave us the guiding force of how to implement this and how to create our own protocol. So the first thing is, what's currently happening with our patients, right? So one, I want to look at how many exams I'm doing per hour. What's my time between exams? How much time are you getting with each patient? Because when you start doing medical testing and when you start having to go over different results and showing them pictures and showing them results and doing everything that we need to do appropriately, how much time do I need for that? How much time can I allot for that? How much time is the patient typically going to ask questions for? Because there's nothing worse than doing an eye exam, getting through it, and then as you're about to finish, they're like, oh, by the way, I have 19 more questions for you that are completely unrelated to the things that we talked about. And you're like, okay, I'm here for you, but this is clearly not everything that we needed to do here today. So what is the current workflow of our patients, not only in comprehensive eye exams, which is how we can convert them into dry eye patients, but what's the current workflow of somebody who calls in saying, my eyes have been bothering me for 2 to 4 weeks, my eyes are itchy, gritty, scratchy, and you need to bring them in and you think they're a good candidate for a dry eye workup. All of those matter, right? So how is your staff answering the phone calls? What does your workflow look like within the office? What can you add into it? So adding a speed sheet for us was easy. I know that in some offices, they will do mybography screening on every single eye exam. If you have the workflow and the time in order to do that, that's a great way for you to pre-screen patients. That's something you can do on day one. It's a decision you have to make because it's time. It takes time to do it. It takes staff to do it. If you have it, great. If you don't, we did it originally, and then we started backing off of it and packaging it with our dry eye workup. The second is, how am I diagnosing this disease now? What technologies are you using in your practice? What therapies do you use or sell in your practice? And what are you looking to add into your practice? And I think all of these three kind of give you a guideline. I don't think you need a lot of technologies in order to start dry eye treatment. The easiest, cheapest, most effective is going to be an iPhone camera attachment. So you can take pictures of the ocular surface and vital dyes, fluorescein and lissamine green, and an iPhone attachment or an Android phone attachment, if that's your fancy, right? Having pictures, being able to stain, and a good survey, and you can treat the majority of dry eye patients out there. Practices like Damon's that is going to have the latest technology across the board and probably has 4 mybographers, 3 different ways for you to treat MGD that are procedures. They're fantastic if you have that space, if you have the time, if you have the capital in order to invest in all that. That's great. You can have as much or as little as you need to. And that's the beauty of dry eyes, finding out what you want to use, what's going to make you feel comfortable. Do you want to have one unit that sits in a separate dedicated room that you can bring someone into, like a LipiFlow? Do you want to have something like a tear care that you can move into other rooms, or an iLux that you can bring into a room and every room becomes a treatment room? Do you have space limitations? All of this is going to matter to you differently than it does for me, because 24,000 square feet in my office with 14 exam lanes. I have space for a dedicated dry eye treatment room. You know, if you're in New York City and you've got 500 square feet for you to do everything, you know, a dedicated dry eye treatment room may not be what you need. So the other thing you need to think about is, what are you stocking? What are you selling in your office? So if you're in a large private equity group, sometimes it's not as easy to sell things out of your office if you have to go through a couple different hoops in order to do that. But if you can, selling products out of your office just helps boost compliance. Before, we did not stock Hydro Eye in our office, and we handed patients a slip and said, go buy this online, come back in a month for your dry eye workup. The number of people that said, oh, I forgot to do that, just got to the point where we're like, you know what, this is too much. Now, every patient that comes in that is a candidate for a dry eye workup is presented and is given the bottle. And then at checkout, they hear the price tag, and 85 to 90% do purchase. 10% are like, nope, I'm not paying any more than my copay. And we get those patients, right? We're going to have those patients come into our office, but every patient that has ocular surface disease is leaving with a supplement at their eye exam. Other therapies that you have, also the prior authorization process. Who do you have managing that? Where are you sending your drugs? If you don't have a specialty pharmacy in your area, look into that, because they are a lifesaver. They help manage your PAs. They help take care of coupons and rebates and all of that, so the patient doesn't have to do anything. We have one in Birmingham that I actually get some of my medications for. They send me a text message, I click a button, my refill is sent directly to my house. So there's nothing better than compliance, than getting your medication and not having to think about it. The next thing you want to think about is, what is our mix of patients and their insurance coverage? So do you have a lot of Medicare? Do you have a lot of commercial? What is the age demographic that you have? If you are a pediatric practice, your dry eye protocols are going to look very different than somebody who's practiced 90% or 65 and older. You know, we have a pediatric optometrist in our office. We see 4 to 94, so we get a very wide range of patients. Our Medicare 65 and older population is probably some of the lowest in the country. We're probably in the 4 to 10% range, depending upon which insurance plans we kind of collaborate with. But 90% are commercial insurances, so not using Medicare. So that changes the type of products that we think about in our office. The other thing that I like to ask is, what are your usual typical patient complaints for eye exams? Are they complaining about itching and watering and dryness and gritty and scratchy and burny and the 92 million other symptoms that we can see for dry eye disease? Or are they just saying, I just need my glasses updated, I'm doing fine? I love the debate on whether fine is a good word. I think fine is the worst 4-letter word to hear from a patient on the planet. Any patient that tells you that they're fine, in my personal opinion, they are waiting for you to make their life better. Because if it were better, they would tell you. If they're just telling you that it's fine, that is, for me, a little red flag. And like the dry eye fairy pops up on my shoulder and says, this person has dry eye. And I'm like, great, I don't even have to do anything. My fairy told you, right? So what are the typical complaints? What are they doing for exams? Utilizing that in order to implement this. How am I utilizing my staff? This is such a huge component to this, to facilitate, whether it's awareness, treatment, protocols, PAs, all of it. The staff grease the wheels. So what are you doing? What does your staff know about dry eye and the therapies now? How do they learn about it? And do I have staff that want to be a champion for dry eye disease? Do I have somebody who wants to take a more active role in dry eye disease? Because having a staff member that you can lean on, that you can turn to say, hey, I need you to handhold through this patient's calling again. Anytime somebody calls and asks a question, they know that there's somebody there in order to take care of their dry eye complaints. Training that champion, giving them the reins, giving them the authority is such a huge uplifting thing to do in your practice. And I can almost guarantee that anybody that's truly successful in dry eye disease has not one, but multiple champions within their office to help talk about dry eye disease. And then secondly is, what's the conversation or what role will the doctors and the other staff play in this protocol? So what procedures are being done by the doctors? What procedures are being done by the staff? What's the handoff look like? What's the interpretation looking like? So what role does everybody play in this? And then, if we talk about converting from vision to medical, so if you have or are thinking about this as your protocol, like you have patients that complain about this all day and you just want to go ahead and get them into the medical side and don't want to do their vision exam today, who has that conversation? How are you going to manage that from the billing perspective, and how are you going to handle the patient? So all of that is, these questions kind of walk you through where you need to go with implementing this. So to kind of go through, so the eye exam, they come in, we're going to fit them in glasses and contact lenses, get them taken care of, unless their dry eye is severe enough to affect everything that's going on. So if it's affecting their contact lens wear, we're stopping that. We're going to treat their eyes, talk about treatment, and move forward. But if there is low-grade ocular surface disease that we can treat and still maintain a good prescription, good contact lens wear, we're not going to abrupt or change course until then. When they come back for their 1 month dry eye workup, they get a tear lab, lippy view, and then they go into the room where they are asked more questions about everything that's going on. How are they taking the hydro eye? If they're having any issues with it, how their eyes are feeling. Then I'll go in, I'll do staining with both lissamine green and fluorescein, take pictures of the corneal surface, and then review kind of everything all at once. So we talk about the tears and why we took that. We talk about the oil glands and how those are looking objectively now, since subjectively we just pressed on the oil glands last time. We'll talk about the staining and the inflammation on the surface, and then we'll design a treatment plan. So then they get their sheet that has all of their treatments on it. So if they get a prescription drop, if they're getting a procedure recommended, if they're doing lid hygiene, if they're doing, I'm trying to think what else we had. We add an artificial tear in at bedtime because their complaints are worse in the morning and they have lag ophthalmos. All of these things matter, and writing it down and giving them something to leave with is tremendously important. So go to the next slide, because this one's the take-home message for all of this is that the beginning part of this is hard, right? Deciding that I want to implement all of this and deciding that it is time for us to change, that's what makes this hard. The middle is the messy part, right? That's where you're figuring out what works, what doesn't. We had Inflamadry. We just didn't see that it was adding enough value into our office. Our reimbursements were paying for the device essentially, or paying for the little things that we got, but it didn't give us enough good clinical data. It didn't connect the dots well with patients, and it just took way more time than I wanted to. So we opted to not use that anymore. But I think the Tear Lab for us works really well because everybody loves a good number. The mybography is tremendously important because it gets to show those oil glands and why procedures are important. So setting that up, and you got to have staining, but figuring out how that works, figuring out staff champions, figuring out the training process for new hires, for optical, for patient services, or anybody who's at reception, because everybody in the office needs to know all of these things. Because when we recommend it in the chair, when they go out to optical and purchase glasses, they might have another question. And I don't want the optician or the eyewear consultant, whoever is there, to be like, I don't know, let me go talk to the doctor again. Because now that just adds more time to patients in the office. It looks like we don't know what we're doing, and it just doesn't communicate effectively across the board. So everybody has to be bought into this, at least enough to be able to have that conversation. But the middle is the messy part. But when you get to the end and work your way through, the end is gorgeous. And then it becomes a well-oiled machine that anybody that comes in, now my staff knows this person scored an 8 on their speed sheet. Let me go ahead and grab their hydro eye because I know he's going to do it. Let me go ahead and talk to him about it. Here's their contact lens wear. I know he's probably going to change it and go to a daily disposable. I'm going to go ahead and plant that seed. So now all of those things, that the little idiosyncrasies that go along with the protocol, are embedded into all of this. And now as we treat, it's written down, they know what to do, and everybody gets to speak the same language. So that implementation part of it and figuring out how to implement it is the hardest part, by all means. Deciding that you need to is like, yeah, you got to make that step. But once we get to the middle, figuring all of that out is the messy part. So having the ability to self-correct. And the other thing I would say is don't give up on the messy part, or saying, hey, let's try this for 60 days, and then at day 15, this is not working, we need to change course. We do this with our patients too. They're progressives, they put them on, they're like, these don't work, and they literally throw the glasses back at an eyewear consultant or an optician and say, oh, can't wear these. We too have to do that. So we need to, in order for us to get through it, work your way through. And I promise you it's worth it to get there and have everybody on the same page. So thank you. Here is my email address and my Instagram account. So please follow. Send me an email if you have any questions. I think we do have time for some questions now. I'll bring Damon back on stage.
Yeah, thanks, Mark. Great job. And several questions here. We just got a couple minutes. One that came up earlier today, I said, I know Dr. Schaeffer is going to talk about it a little bit, and you just mentioned it, but where can people go for more information about contact lens dropout and then how much of an impact that is in your practice?
Actually, I wrote 2 articles on it. One's on Eyes on Eye Care. So if you go there and search contact lens dropout, the dropout rates are about the same, right? They're 20%. We've had just increases in parameters, increases in technology. We now have things that increase oxygen content beyond a reasonable amount, right? Like above and beyond. We now have daily disposables. We're asking our contact lenses to do a lot more, and our surface just can't keep up. So we need to, in order for us to have successful contact lens wear, we have to address the surface before it becomes a problem. Because if we don't, our patients will drop off, get into glasses, and then they stretch out their exams. They're less satisfied with their eye care. And then they become to a point where we can't rehabilitate them. So making sure that those contact lens patients who are saying, my lenses are a little bit dry at the end of the day, my vision is fluctuating, listening for those cues, my multifocals just aren't as sharp, that is a key in. Maybe it's not the prescription, maybe it's the surface, but it's probably both.
Final question, 2-part, is, are you using any sort of device to express meibomian glands? And if you do you do that yourself, or does your staff do it?
Yeah, so we actually have 3 devices. So we have the MiboFlow, we have the LipiFlow, and then we have the TearCare. So in that order, it's only technicians do the MiboFlow because it is on the surface of the eye. For LipiFlow, I will insert the activators, and then I'll have a staff member sit during the 12-minute procedure time. And for TearCare, the doctor, I will put on the activator, set the timer at 15 minutes, we'll put them in exam room, and then I will express the oil gland. So it's a mixture of all, but again, more in-service, more training, more hands-on experience, but having the ability to have 3. We've had all 3 and had great success with all of them, so it just depends.
Thank you, Mark. That was a great session. We've got one more session today. You've got 15-minute break here. Go to the exhibit hall. You can go and check out a lot of these technologies that Dr. Schaeffer mentioned. Also look at the different diagnostics, things that can help you with bringing these things into your practice that are OTC. So lots of opportunity to accelerate your dry eye practice in really any practice setting, including primary care. Dr. Schaeffer, thanks again. I hope to see you back again soon.
Thanks, y'all. Have a great afternoon.